everyone. Welcome to the Preemie Chats. Preemie Chats is our weekly educational sessions for healthcare professionals and parents to talk about what matters to you, to explore new ideas, and to learn together. I'm Fabiana Bacchini. I'm a Preemie parent and executive director of the Canadian Premature Babies Foundation, as known as CPBF, and I'm happy to be your host today. CPBF is a parent-led organization that helps families in and after the NICU through support, education, and advocacy. If you have a heart for preemies, whether you are a family or a healthcare provider, please check our website at canadianpreemies.org. There you will find resources, the latest projects, and most importantly, a community of people who wants to see our little babies thrive. And today we're going to talk about disability in the NICU, parents and babies. In this presentation, our guest, Shannon Rayon, will talk about her experience in the health system and how disability, from the point of parents identified as disabled, was discussed for labor and delivery planning, but when was then never talked about post-delivery or in the NICU. Conversations related to infant disability center around skill sets like learning about trachs and vents, but excluded psychological teachings. And I have here join me Shannon, who is a mom of two. With her oldest, she spent 4 months in the NICU at McMaster Children's Hospital. Shannon and her son both have a congenital central hypoventilation syndrome, a chronic breathing syndrome which requires ventilation every time they sleep. Shannon does advocacy work surrounding supporting disabled parents in labor and in NICUs. Shannon is also a registered social worker and a PhD candidate at the University of Waterloo, where she studies the mental health outcomes of youth living with chronic physical illness. Shannon, thank you so much for joining us today. This is such an overdue chat with you. We've been talking about this for quite a long time, so I'm very happy to have you here today with us.
Thank you, Fabiana, for having me.
So Shannon, you can actually bring your slides up.
Okay.
It's just going to take a minute or so. And then at the end, we can have a Q&A. But for you watching us today, this has been a pre-recorded session. So you're not going to be able to ask live questions, but you can certainly send them comments that Shannon will address in those social media channels. Shannon, the floor is yours.
Okay. Thank you, Fabiana. Can you just confirm that you can see my slides?
Yes, perfect.
Perfect. Thank you again, Fabiana, for hosting me today. I really appreciate the opportunity to share more about what it's like being a disabled parent in the healthcare system, specifically being a pregnant mom and also parenting a disabled child. So in this picture here, you see my son and I when he was about 2 years old, what the medical equipment he has. We go everywhere with it. And he is trached and vented. So he had a tracheostomy for the first 5 years of his life. And I'll share more about our journey through that. This is a brief overview of what I'll be covering today in the roughly 30 minutes I'll be talking for. So I'm going to share first about what our disability is, congenital central hypoventilation syndrome. I'll also be sharing a little bit about physical disability research, and then I'll be diving into what it was like being a disabled mom during pregnancy, labor and delivery, and my experience in the NICU, both as a disabled mom and a mom parenting a disabled child. And I'll also be briefly covering what it's like to have a disability during COVID-19. And then I make some suggestions for how we can really advance disability inclusion in healthcare settings, sharing some resources along the way. To begin, what brings me here today is congenital central hypoventilation syndrome. So we often refer to that as CCHS for short. CCHS is an orphan syndrome. There's only about 1,200 people worldwide with it. I am the third oldest one in Canada with CCHS. It is a neurological disorder with respiratory symptomology, and there's a spectrum of it too, going from mild to more severe cases. The case that my son and I have is actually considered more on the milder side. It is also genetic, there is no cure, and it is lifelong. How CCHS presents is you typically stop breathing or you underbreathe every time you sleep. In more severe cases, CCHS can be associated with cardiac pauses, Hirschsprung's disease, neuroblastomia, and ophthalmology issues. Regardless of what severity form of CCHS you have, it's all treated the same way in regards to the breathing presentation and symptomology, and that is every person with CCHS relies on mechanical ventilation to breathe for them. So that ventilation can be provided via a tracheostomy or a BiPAP with a face mask or phrenic nerve pacemakers. If we take a look at this slide here, on the left, there is a picture of a white tracheostomy tube. The tube sits below the vocal cords, meaning that it is harder for people living with tracheostomies to vocalize and for sound protection. So typically in CCHS, infants and small children are usually trached because it is too hard and challenging to ventilate a baby or a small child over the nose using non-invasive ventilation. But thankfully, as that child ages, they are able to make a choice as to whether they want their tracheostomy removed. Some patients will progress to a non-invasive ventilation, meaning in this second picture that they'll use a face mask attached to the ventilator. And then once they're older, some people choose to get rid of that external ventilator altogether, along with the face mask and tracheostomy, and move to what's called a phrenic nerve pacemaker. On the right, you'll see what the phrenic nerve pacemaker is. It requires a surgical operation in which surgeons put a lead around the phrenic nerve, which is attached to a receiver just below the diaphragm. And once you hook up your external transmitter, it looks like an old style walkie-talkie over those receivers, that will send an electric shock to your phrenic nerve to pace the diaphragm so many beats per minute. So walking through these transitions, I was trached as a child until I was 8 years old. My son was trached until he was 5. And my son made the transition to the face mask when he was 5. And then at 16, I got phrenic nerve pacemakers. I'm going to be touching a little bit on the research surrounding chronic physical illnesses in pediatrics. So about 42% of children living with chronic physical conditions will develop a mental illness at some point in their early years. The overall day-to-day functioning declines from physical illness only to mental illness only to physical mental comorbidity. So as soon as you add a mental diagnosis on top of a physical health condition, the overall day-to-day functioning declines. However, the good news is that the risk for mental health issues declines with the mom being employed, and that's a protective factor for both poor maternal and child mental health. The other positive news is if there is coordinated care for these really medically complex families with high quality nursing, that can offset mental health risk as well, because parents spend about 2 hours per week coordinating their child's care and at least 11 hours per week providing nursing level of care. It's also important for healthcare providers to know that having a sick parent creates a family crisis. As you can imagine, if a parent becomes sick and is the main caregiver of a child living with a tracheostomy or a ventilator, that requires special medicalized skills to care for that child, and a sick parent will really create a medical crisis. So the reason why I shared that research is because it's important for healthcare providers to know about that if you're to provide family integrated care. And on this slide here, I wanted to include the complexity of my son's discharge from the NICU in McMaster from 2016. So after about a 4-month stay with our son in the NICU, we had 19 different health professions involved in his discharge planning. They're all listed on the screen here. So it really provides a picture backing the research that says parents spend so much time coordinating their child's care, and that we really need to look at innovative ways to provide complete coordinated care amongst healthcare systems. So now that my son is 7, the intensity of the day-to-day nursing level of care has decreased, but now we're learning how to get the proper supports for him within the education system, as he has an IEP for his medical needs, as well as because he's now neurodiverse. Specific to my experience being a disabled mom and pregnant, I'm going to be sharing now that pregnancy journey and delivery and NICU stay, now that you know more about CCHS. So disability in pregnancy, about 1 in 8 pregnancies in Ontario are to disabled people. Specific to my situation, as soon as I found out I was pregnant with both of my pregnancies, I was quickly followed by the maternal fetal medicine clinic out of McMaster Hospital in Hamilton. With my son, we received a positive genetic test via amniocentesis when I was about 5 months pregnant with him. For both of my pregnancies, myself and my maternal fetal medicine specialist really co-developed a delivery plan. So I remember the first meeting I had with my specialist. She had brought research, which was great to see, but unfortunately it was of a case study of another adult that had given birth to a child as well. And in that specific case, that mom living with congenital central hypoventilation syndrome opted for more conservative treatment and opted for a planned C-section. I wanted something a bit different. So I wanted to be induced with a planned delivery, but also having a vaginal birth. So my specialist was very supportive of that. And together we were able to co-develop a plan that kept me safe and kept both of us comfortable. And because my maternal fetal medicine specialist really treated me as a co-developer in my labor and delivery plan, I felt very confident and at ease once I was in labor and delivery, and I felt well cared for. So it's very clear that there was family integrated care happening in the maternal fetal medicine clinic. And I experienced that for both of my pregnancies. However, being a disabled mom, I often ran into conversations that had ableist undertones in them. And a lot of that included language that was not disability inclusive. So language such as, how long have you suffered from this condition? Tell me all the bad things about this. And other things like that, which really spoke to the ableism undertones. So I would often go for my ultrasounds, and some of the texts would often use that word suffering. And for me, that implied that disability is tragic and that it was something to be overcome or that you are less than. So as soon as I heard language that was like that, it made me feel that this pregnancy was not as valued as other pregnancies. Moving on to disability in labor and delivery, there were a lot of good things that happened. So for example, I've already touched on co-developing a labor and delivery plan with my maternal fetal medicine specialist at McMaster. So that was done with both of my pregnancies. I found that my labor and delivery nurses asked really good questions and asked what my preferences were. It was clear that none of them had had experience with this specific disability, but they posed really good questions and in a way that was conducive to making me feel welcomed. And they asked questions surrounding my physical environment and how I would like it set up and what they could do to accommodate that. So here on in the picture on the right, that's my daughter a couple minutes after I had her. And I just felt that through both of my labor and deliveries, the physical environment was really set up with how I wanted it to be. And maybe that was due to having the space that I needed in the step-down ICU unit to be able to configure everything how I wanted it to be. Specific to my son's delivery, we knew that he was going to have to be transferred to the NICU shortly after he was born, depending on how long he stayed awake and how quickly he fell asleep. So thankfully, we had about 27 minutes with him before he started dozing off and he needed to be intubated to breathe for him while he was sleeping. While he was transferred to the NICU, my husband did that transfer, and I was back in the delivery room still, having to deliver the placenta and everything else. So it took me about 3 hours post-delivery to get to the NICU to see my son and be involved in his care. But during those 3 hours, I really found that my labor and delivery nurses and the step-down ICU nurses were really good at providing trauma-informed care. So they were all well aware of what was happening. They read my chart, they comforted me, they walked me through everything, and they didn't leave my side at all. And they also made sure that I was able to go to the NICU as quickly as possible once it was safe to do so. Even though all those good things happened in the labor and delivery, there were barriers that I experienced with both of my pregnancies. So the first one was, again, surrounding the language that staff use around disability and the undertones in that language. I found that specific to my daughter's labor and delivery, there was really a lack of continuity in care, and I'm not sure if that was because she was born halfway through COVID and all the staffing challenges, or if it was something else. But I found that in my son's care, I saw the same specialist each time, and there was almost over planning to a certain degree. Whereas with my daughter, we knew she wasn't going to have CCHS, but there was a lack of continuity of care. So I found that as a disabled mom, I only saw the same specialist maybe once, and on the day that I was induced for my daughter, I hadn't even met the specialist who was going to be delivering her and caring for me. So I found that I really had to repeat my story multiple times, which was really frustrating. Also related to my daughter's labor and delivery, there was a lot of delays in being medically cleared and in receiving consultations. So, for example, I delivered my daughter safely and everything went smooth and well, thankfully. However, it took over 8 hours to be medically cleared. And within that time, there's a hospital policy that states that disabled moms or parents cannot care for their newborn independently if they have not been cleared. So I knew that I was back to my baseline, that if I were to be home right now with my daughter, I'd be up for parenting her and doing everything I needed to do independently. But in this hospital setting, I wasn't allowed to be left alone with her. And that really bothered me because it was as if my parenting was being doubted and my capacity as a parent was not valued, even though that it might look a bit different. There was also delays in receiving a lactation consultation, which was really important because with my older son, I didn't really have the opportunity to breastfeed him that much. And with my daughter, I knew I wanted to at least attempt to breastfeed. Yet there was a huge delay in receiving that lactation consultation. And that was really important to me because we were told by a nurse that it was possible that our daughter might have to be admitted if she wasn't feeding properly, which would have delayed discharge for her, which just triggered a lot of anxiety from our previous NICU stay, as well as creating anxiety from knowing that we had a son with complex medical needs at home that we wanted to get back to. So all these delays created barriers for us in terms of what parenting looked like and in my capacity to parent. In terms of my son's labor and delivery, there was a lot of barriers in terms of there being no direct communication from post-delivery to the NICU. So even though my husband was able to go with my son to the NICU, I wasn't able to participate in conversations or advocate for him because there was no direct communication to the NICU. Some of the good things that happened during our NICU stay is related to family integrated care in the NICU. And this is often touted as engaging parents in rounds and letting parents lead the rounds. The other thing that's really important is, I'm sure everyone's aware, is kangaroo care. So in this picture on the right, staff really made me feel valued and needed, and like I was the lead of my son's team. And they showed this by taking the time to get my son and I situated for kangaroo care, which is no easy feat when you need an RT and a nurse to supervise that and to get that all set up. And that was quite the time-consuming process for staff, but they were able to do that, and that really showed that I was needed in the NICU and that I was valued, and that even though my son and I had a disability, we still figured out how to make this work. One of the other facilitators is educating and training parents on their baby's medical needs. So that's a big component for any child with a tracheostomy and ventilator, and we were given 3 months of training. Now, once we left the NICU, I learned that there were peer support programs that were offered, as well as mental health support programs with partner agencies. Unfortunately, those two programs were not available when I was in the NICU, but that has since changed. What was available for us was we had a pre-admission tour of the NICU before I went into labor and delivery, and we were actually able to meet the neonatologist caring for our son once he was born. So that really helped us mentally prepare for a NICU stay. And I also found that there was a lot of coordinated care between the NICU and the complex care team, which is a team that trains parents on tracheostomies and ventilators and oversees that sector of the pediatric patient population. Even though there was excellent examples of facilitators of NICUs and specifically being disabled as a parent in the NICU, there were quite a few barriers. So as you can imagine, if a disabled parent with mobility accommodations are in the NICU, that space is very small, and I'm not sure how conducive that would be. And also, if we want to talk specifically in relation to CCHS, you rely on technology for a ventilator, and you also rely on power and electricity for that ventilator. So as you can imagine, there's really small space in the NICU, and there's not always a free electrical outlet nearby. So that really limited my ability to stay there when I was tired and sleepy, because one, there was no place for me to plug in my ventilator, which I was temporarily using post-delivery. And two, there's hospital policies that won't let outside medical equipment come into the space. So that was a huge barrier as well. From a trauma perspective, if we think about the physical environment, there's often many alarms going off in the NICU, as well as codes like code gray, which is an electrical power outage, or a code pink, a respiratory distress in a newborn. And those codes and alarms can often be triggering from past healthcare experiences and traumas that disabled parents might be going through. Another barrier is that even though the NICU and the complex care teams provides more than enough education on teaching parents how to physically care for their child's medical needs, there's really no training or education provided at all that includes psychosocial disability education. So a lot of the education was deficit focused instead of being strengths focused and focusing on not just the psychosocial outcomes of youth living with physical illnesses, but also talking about resiliency and how to promote that. There was also a lack of flexibility in education delivery. So even though I had gone through each stage of what it's like to live with CCHS in terms of progressing from a tracheostomy to a ventilator to a phrenic nerve pacemaker, there was no flexibility in terms of letting myself care for my son, such as turning the ventilator on and off or suctioning his trach, without first having going through the technical education program at McMaster. So I found that very not family centered at all, or even adhering to the principles of family integrated care, because again, it doubts your capacity as a parent to provide that, when really there needs to be flexibility in that education and an acknowledgement that some of those skill sets already exist, and perhaps we can sign off on these skill sets more quickly once that's demonstrated. As a disabled parent, I was surprised with the amount of advocacy that was also needed for orphan disabilities in the NICU. So I often found myself explaining CCHS to basically every new staff member, and also advocating that even though our son was trached and vented, he was able to come off that ventilator when he was awake, to especially promote physical development and every other type of development as well, because a lot of the nurses were associating his trach and ventilator with issues of a preemie, but our son was actually born at 38 weeks, and there was a lack of acknowledgement that the ventilator was just for sleeping. So I really needed to push for him being off that ventilator as quickly as possible once he woke up, making sure it was on when he was sleeping, and also really advocating hard for oral feeds for him, as most nurses had never seen a trach baby orally feed before. It's also important for staff to know that even though a disabled parent may be familiar with adult funding programs like assistive devices program or the ventilator equipment pool, and advocating different insurance funding programs, that those systems can be very different for the pediatric world. And that's a world that disabled parents may not have had to advocate for when they were younger with a disability. So it's important to at least ask them if they're aware of different programs and how to access them. It's also very important to educate parents about the differences between hospital nursing and home care nursing. We were shocked to come home and be discharged to a nursing team through an agency that often sent us nurses that did not even suction a tracheostomy before, never cared for a ventilator before, or just did not have competence with even turning on oxygen. So I really found out quickly how to advocate for more proper nursing in a home care setting and how to address those issues. And it's also really important for hospitals and parents to come up with backup plans for childcare. As you can imagine, if my daughter is sick, I can send her to grandparents or to aunts and uncles to be cared for. But for my son, there is specific medical skill sets that are needed. So if I'm to become sick and I'm not able to care for him, what is the backup plan? What's going to happen? That was never discussed in the NICU. And unfortunately, when my son was about a year old, I fell on ice and broke a couple of ribs and a tailbone. So we were in full crisis mode and not really knowing what to do when a plan could have been established in the NICU. Moving along to disability during COVID, sometimes disability is talked about as temporary, when in reality, 90% of youth with disability become adults with disability, and disability just doesn't end once a baby is discharged from the NICU. However, fast forward 4 years, and our son is now 4 years old, and COVID hits. We knew that myself and my son fell into this vulnerable category of having a respiratory disease and being vulnerable to COVID-19 exposures. But there was no sense of information or what that severity of vulnerability would be, because there was a lack of communication from both the local health integration network as well as the complex care teams, which really created a lot of anxiety. It's also important to know that even though hospitals had significant shortages of PPE, home care agencies that provide nursing supports to pediatrics that have tracheostomies and ventilators, whom are supposed to be 24/7 eyes on care, that these nursing agencies had no access at all to PPE. So what a lot of families did was just cancel their nursing entirely because of the risk of bringing COVID into your home and possibly exposing that nurse as well. And that really created a lot of emergencies for families. I know for ourselves, we really reduced the amount of nursing we had in our home, which created a lot of sleep deprivation and family functioning issues as well. However, in 2021, our son started kindergarten, but we opted to keep him home. And the reason for that was, one, he was still vulnerable to COVID, and two, because the schools had implemented this policy where any aerosol generating medical procedure, meaning anything done with a tracheostomy or a ventilator, like suctioning a trach or turning on a ventilator, that's considered aerosol generating medical procedures. That the nurse attending school with that child that relies on a tracheostomy and ventilator would have to be in full PPE. We certainly understand the masking requirements, but the full PPE really centered a lot of children out, especially when other adults in the school were not wearing full PPE. These are some suggestions I have about including more inclusive disability practices in healthcare. So the first one would be to include disabled people in hospital policy making and staff training. So when I talk about hospital policy making, it would be important to prioritize post-delivery visits to disabled parents. So for instance, if I was medically cleared soon after having my daughter, then I probably would not have felt that my parenting capacity was being questioned, and I would have felt valued as a parent as well. It's also important to include disabled people in staff training so that staff knows what it's like for people with disabilities in the healthcare system, and really questioning any biases or stereotypes that they might have about disabilities, and really promoting inclusive language as well. It's important to include disabled people in environment design. So that could really help access different, like really small spaces in the NICU, and to have people with different disabilities included in that process. It's important to have peer navigators with disability experience. They would have had experience navigating different funding programs and different agencies and the communities, and that would be valuable to parents. Another consideration would be to have NICU live video feeds. So if a disabled parent is recovering in a step-down unit, but their child is in the NICU, that parent can still participate in conversations and look in on their baby if there was a live video feed. And again, prioritizing post-delivery visits to disabled parents is necessary to promote parenting and to also have those feeding consultations as well. And one thing that's really important that there's a huge inequity right now is offering midwife programs and public health visits to disabled parents. So I know that at McMaster Hospital, there is currently a pilot program for a midwife program within the maternal and fetal medicine unit. So if I lived in Hamilton and I was pregnant, I could have access to this midwife program. However, you have to be in the city, and living rurally, it's still not an option. And I would have loved to have that option because I would have loved to have the same equitable access to midwife care. I would love to have a midwife come to my home and weigh my child and give me feeding advice and just check in on us as well. It's also, our home is an environment where our accommodations are set up how we want it to be, and we're most comfortable here. So anything related to baby's care is important to go over in their home. And lastly, if we're to talk about family integrated care, that means screening parents for disability needs. So you aren't going to know about disability needs unless a parent discloses them or if you actually screen for them. So that could help with creating a safety backup plan, and it can also be used in continuity of care as well. These are some resources that can help guide disabled parents as well as healthcare professionals in knowing how to include disabled parents in NICU settings and in labor and delivery and pregnancy. So the Dear Everybody campaign is out of Holland and Blue Review. It's youth-led, and it's an amazing program that really tackles discrimination as well as promoting inclusive practices and languages that youth have driven and are promoting. And there's a lot of lessons to be learned from that can be carried over to pediatric healthcare as well as in adult settings. The Provincial Council for Maternal and Child Health offers resources for healthcare professionals and administrators in terms of statistics on disabled pregnant people. And if you're curious to learn more about CCHS specifically, you can go to the CCHS network to read more patient stories and to read more about the science behind it. And lastly, the United Nations has great resources on its website specific to people with disabilities and the rights surrounding fertility and parenting of people with disabilities as well. Thanks, Fabiana. I'm going to end that there.
Thank you, Shannon, for, eye-opening presentation. I had to tell you, 10 years doing this work, and I've learned so much from you and identify so many gaps that we still have so much work to do ahead of us, so everybody feel included and seen and heard in the NICU and prepared to take their babies home. Wow, what a journey you had. I know you for a few years now, and I know how much advocacy you've been doing for families, and really appreciate you for that. One question that I have for you, let's talk about communication, because
Yes.
you talk about language, not inclusive language. How can we make this better? This is a communication is an issue across the board, pediatric, adult care, end of life care. So how can we make better in your situation, specifically when we have a parent with a disability in the NICU?
I think the first thing that people can do is, one, ask the person with the disability how they want to be referred to. just like how we are starting to ask about pronouns, asking disabled people if they want to be called disabled, if they want to be referred to a person living with a certain disability, and also being very aware of biased language that they might be using without even knowing about it, and really being aware of the connotations associated with certain words like suffering.
Yes, and well, I have a child disability, and we know very well how it is when people address their child and feel sorry for your child, and all that. That we have a lot of work to do for sure. But I think in the hospital setting, we have to really target the communication and how we can talk with compassion and inclusivity in the NICU specifically, because a place of trauma, as you mentioned. So talk about trauma. You mentioned that you are prepared to care for your child at home from the physical aspect, for the tubes and the trach and the ventilator, but not from the psychosocial support. You live in an area that is not a main city. So the lack of psychosocial support for you was in the NICU or going home, knowing you experienced a trauma, and it was hard to access because you don't live in the big city. So let's talk a little bit about that piece.
So there was really no strength-based conversations that happened in the NICU regarding disability. It was all from a deficit perspective. And as a disabled parent myself, that was really concerning because disabled people have a lot to offer. And if we're only talking about it from a deficit perspective, we're missing this whole different side, and we're missing the whole person. And we're missing everything that they can offer. So if we talk more about the psychosocial piece, we can really talk about those strengths that disabled people offer. And we can talk about how parents can promote that in their children as well. And once they age, how can they have those disability conversations with their child, like in terms of teaching children how to talk about their disability and making sure that they feel safe about talking about it with peers and people at school. So teaching parents that, as well as coming from a rural community, accessing mental health support was just very challenging because those resources were typically in city centers that required transportation. And with our son having complex medical needs, leaving him for any extended period of time was just not an option. Thankfully, now with virtual visits, it's a lot more accessible, but we constantly need to consider how different disabilities need to be accommodated for accessing mental health supports.
Absolutely. So now, how old is your daughter?
So our daughter will be 2 next month.
Wow. So let's talk about family life now, because when I saw your son's care map is overwhelming. So many appointments, so much piece of equipment you have to carry around. And then you have a second child. How is family life for you now?
It's crazy. With all the different activities they're in. It's certainly fun. As a disabled person, you get really good at planning. So making sure that you plan a lot about what equipment you need to bring, make sure you're not missing anything, and to also have backup plans as well. So life has gotten a lot easier since our son decided to transition from a tracheostomy to just a ventilator. So that was very good because we're no longer having to suction his trach up to 50 times a day some days. So that's freed up a lot of time, which has been really nice.
Well, and managing nursing at home, is it easier now as he got older, got off of the track, is on the vent? You have less issues with nursing?
Well, I would say nursing is still a big issue, and that's because of the nursing shortage, not just in hospitals, but it's even more pronounced in home care settings. There's a huge shortage of nurses, qualified nurses in tracheostomies and ventilators in home care settings. So it's actually become more difficult over time. to retain those nurses.
Okay, Shannon, I would thank you so much for your time today, for all your tips on how can you make things better. Thank you for your ongoing advocacy. I'm sure families, you're going to leave a legacy for many families who come after you to hopefully to experience something a little better than you do and make lives a little easier for others after us. So thank you so much for being with us today.
Thank you, Fabiana.
And to all of you watching us today, thank you so much for joining us. And I was also want to thank our sponsor, AstraZeneca, who makes education sessions like this one possible. And just a reminder that if you missed part of today's session, head over to canadianpreemies.org. Let me just put here our website to see this episode and all past sessions of our Preemie chats. You'll find many resources and support options available there. And you'll also be reminded that CPBF is a charitable organization and depends on support to continue its important work. Consider how you can support CPBF in its mission to empower families of premature babies every step of their journey. Together, we can create a brighter future for all preemies and their families. And we'll see you again next Friday, 1 p.m. Eastern Time.